talk about abdominal distension and then later jaundice. So a few quick questions lang. So what do you call the elevation of the jugular venous pressure during inspiration? What do you call that? So when you do your physical exam, especially if you're dealing with somebody with heart failure and abdominal distension, you check the JVP. If it's elevated during inspiration, what do you call that?
Cosmol sign, Doc?
Yes, so that's the Cosmol sign. And then, ito, last na lang question. What is the minimum amount of acidic fluid detectable on physical examination? So if konti pa lang ang ascites, usually you will not be able to detect it on PE when you do your fluid wave or your shifting dullness. So what is the minimum amount of ascites present to make it detectable on physical exam?
500 ml.
So it's actually 1.5 liters or 1,500 ml. So abdominal distension is a manifestation of numerous diseases. It can be described by patients as bloating or abdominal fullness, and the patient may notice an increased abdominal girth on the basis of increased clothing or belt size. So usually you can ask them, have you noticed if you're wearing belts na you had to move it several holes up, or have you noticed that your clothes are getting more masikip, or you've had the need to buy bigger clothes? Abdominal discomfort can be reported, but pain is usually infrequent. So when abdominal pain does not accompany swelling, it is frequently the result. When abdominal pain does accompany swelling, it is frequently the result of an infection. So there can be peritonitis or pancreatitis, and patients with abdominal distension from ascites, meaning fluid in the abdomen, may report a new onset of an inguinal or umbilical hernia. Kaya napupush ng fluid ang intestines out. Dyspnea may result from pressure against the diaphragm and the inability to expand the lungs fully. So remember that above our liver is the diaphragm, tapos kung duruda mong fluid, mapupush talaga ang diaphragm, so maiipit ang lungs. So it's possible that you will have difficulty breathing. It can be remembered conveniently as the 6 Fs: flatus, fat, fluid, fetus, feces, or fetal growth. So flatus. The normal intestine, small intestine, contains approximately 200 ml of gas made of nitrogen, oxygen, CO2, hydrogen, and methane. Nitrogen and oxygen are consumed. So when we swallow it, if we're chewing a lot of gum, and then whereas carbon dioxide, hydrogen, and methane are produced intraluminally. So nitrogen, oxygen, again sa swallow, all the rest, they are produced inside. Increased intestinal gas can occur in a number of conditions. Aerophagia, the swallowing of air, can result in increased amounts of oxygen and nitrogen in the small intestine and can lead to abdominal swelling. Usually it is from gulping food, chewing gum, smoking, vaping, or as a response to anxiety, which can lead to repetitive belching. Flatus, so your utot, is a consequence of bacterial metabolism of excess fermentable substances such as lactulose and other oligosaccharides, which can lead to the production of hydrogen, carbon dioxide, and methane. In many cases, the precise cause of abdominal distension cannot be determined. In some persons, particularly those with IBS, and bloating, the subjective sense of abdominal pressure is attributable to impaired intestinal transit of gas rather than an increased gas volume. Abdominal distension, an objective increase in girth, is the result of a lack of coordination between the diaphragmatic contraction and the anterior abdominal wall relaxation, a response in some cases to an increase in intra-abdominal volume loads. Occasionally, increased lumbar lordosis. So especially when we're pregnant, mas lordotic na ikaw, accounts for apparent abdominal distension. So fat. So abdominal distension can be from fat. So when you gain weight, this is because there's an imbalance of caloric intake and energy expenditure. Remember that as we grow older, our metabolism will be slower, so we'll need to move more and take less calories. And then it can be a manifestation also of certain diseases like Cushing's syndrome, and it is associated with an increased risk of insulin resistance and cardiovascular disease. So we should exercise. Fluid naman, the accumulation of fluid within the abdominal cavity, like ascites, is often results in distension. So this is a male patient. See that he has an umbilical hernia because of all the fluid there. Tapos fetus, usually at 12 to 14 weeks, noticeable na ang increase in abdominal size. Prior to that, you can still hide your pregnancy if you wish. Hindi siya masyadong obvious. Abdominal distension may be seen before this point as a result of fluid retention and the relaxation of abdominal muscles. Feces naman, so this is actually a part of the intestines and it's filled with feces. Kasi may obstruction somewhere. In the setting of severe constipation or intestinal obstruction, increased stool in the colon leads to increased abdominal girth. Hindi nakakagawas, so it's all stuck there, leading to an increased abdominal girth. These conditions are often accompanied by abdominal discomfort or pain, nausea, and vomiting, and can be diagnosed by imaging studies. So fetal growth, as you can see, there is a certain area lang that is enlarged. It is irregular. It's not like when you have ascites here na parang uniform ang pagkadako. In fetal growth, there are certain areas which bulge out. Bladder distension also can result in abdominal swelling, malignancies, abscesses, and cysts can also grow to sizes that lead to increased abdominal girth. So how do we approach our patient? You should pick up symptoms suggestive of malignancy like weight loss, night sweats, anorexia, and then inability to pass stool or flatus together with nausea and vomiting suggests an obstruction. So something is not, the food that you've taken in is not moving down. That's why you're having an increased abdominal girth. So this is Steve Jobs. If you compare how he was in 1998 to 2008 when he launched iPhone 2, yun, grabe ang weight loss because he was battling cancer at this point. Increased eructation and flatus may point towards aerophagia and increased intestinal production of gas. And you should also look for risk factors of chronic liver disease. So you ask about alcohol intake, how much, how often, and jaundice. And these can suggest ascites ang reason for your abdominal increase. Tapos the symptoms of medical conditions including heart failure and tuberculosis, which may also cause ascites. So here we're looking at lymphadenopathies, this one. So cervical lymphadenopathies, this is a Virchow's node suggesting metastatic abdominal malignancy, and then elevated jugular venous pressure, elevation of the JVP during inspiration, that was small sign, a pericardial knock, which may be seen in heart failure or constrictive pericarditis, or spider angiomas, pulmonary erythema, and dilated veins around the umbilicus that will suggest cirrhosis. Remember, when you do your abdominal PE, it's in this manner. So inspect, look first, auscultate before you touch. Because once you touch the abdomen, pwedeng mag-increase ang bowel sounds, and pwedeng maging different na ang findings mo for your for your auscultation. So inspect, auscultate, percuss, palpate. That's the sequence. Look for uneven distension or an obvious mass. Sometimes you'll see something jutting out na. Absence of vowel sounds or the presence of high-pitched localized vowel sounds points towards an IO, intestinal obstruction, or an ileus. An umbilical venous hum may suggest the presence of portal hypertension. Gas versus fluid versus mass, always do your percussion. So when you percuss, remember that gas is tympanitic. So if you have not had the chance to do a physical exam in person, if you have your Bates na book, sometimes it comes with a CD with the sounds, or you can also search YouTube para you'll know how a tympanitic abdomen sounds. Mass or fluid is dull. So, but when you get the chance to do your clinics, always do a complete PE of the abdomen. Absence of abdominal dullness, however, does not exclude ascites because a minimum of around 1.5 liters is required for detection. You palpate to assess tenderness, a mass, enlargement, a nodular liver. Tapos imaging, yun. If you have an abdominal X-ray, dilated loops of bowel should suggest an intestinal obstruction or ileus. Around 100 ml of acidic fluid, hepatosplenomegaly, nodular liver or mass can be seen on ultrasound. And then CT scan can point to CT scan findings can elucidate malignancies such as malignancy, colon malignancy, cirrhosis, portal hypertension. So what about labs? Remember that liver function, the true liver function tests are albumin, ProTime, and these can be impaired in severe cirrhosis. CBC, cytopenias from portal hypertension or leukocytosis, amylase or lipase can point to pancreatitis. Nephrotic syndrome can be seen if you have spillage of urine. So this is a nodular liver. Liver, once the architecture is distorted, also the functions are also distorted. So smooth dapat ang liver. This is a very ugly liver cirrhosis. Tapos, how do ascites form? With cirrhosis, you have portal hypertension. So the liver becomes stiff and then the portal pressures increase. To compensate, the splanchnic vasculature dilates, and this leads to arterial underfilling and activates the vasoconstrictors and anti-natriuretic factors. It leads to sodium retention, plasma volume expansion, and this leads to ascites. Non-cirrhotic ascites can be from peritoneal carcinomatosis, peritoneal infection, pancreatic diseases. Peritoneal carcinomatosis can result from primary peritoneal malignancies like mesothelioma or sarcoma. And then abdominal malignancies such as gastric or colonic adenocarcinoma can also cause it. It can also be caused by tuberculosis, which is very common in our setting. And then pancreatic ascites results from the leakage of pancreatic enzymes into the peritoneum. Majority of ascites is caused by cirrhosis, but sometimes you can have mixed ascites na dalawa ang causes or more. Less common causes of ascites include massive hepatic mets, infection, pancreatitis. So to evaluate paracentesis, ideally all ascites should be drained and everyone with new onset ascites should undergo a paracentesis for diagnosis. So when we do a paracentesis, we insert a needle and a tube to drain all this fluid. And these are examples of the acidic fluid na drained. It is usually send for albumin, total protein levels, cells, and differential counts. And if infection is suspected, you do a gram stain and culture. And then serum albumin level should be measured simultaneously to permit the SoAd, the computation of SoAd. So SoAd stands for serum to ascites albumin gradient. So this is the SoAd. So you will compare the serum to ascites albumin. If this is greater than 1.1 grams per deciliter, you'll see if the acetic protein is less than 2.5 or greater than 2.5. Pag less than, it's because of cirrhosis, Budd-Chiari syndrome, liver metastasis. If greater than 2.5, heart failure, Budd-Chiari, IVC obstruction. If SoAd is less than 1.1, then it's from a biliary leak, nephrotic syndrome, pancreatitis, or TB. What do we do to patients with ascites? You put them on a low-salt diet, you give diuresis, do parasitosis, offer tips. You can actually put a semi-permanent catheter there, so parang may gripo attached to their belly, tapos you can turn it on, turn it off to drain fluid. Spironolactone is potassium sparing. It's an aldosterone antagonist that inhibits sodium resorption in the distal convoluted tubule. So remember that where salt goes, water goes. So since it inhibits sodium resorption, the water, it will help diurese the patient. Use of the spironolactone may be limited by hyponatremia, hyperkalemia, and painful gynecomastia. If gynecomastia is distressing, amiloride can be substituted. Furosemide is a loop diuretic that is generally combined with spironolactone in a ratio of 40:100. So this is the isokalemic dose para diri mag-hypo-K or hyper-K. Maximal daily doses of furosemide are 400, and for spiro it's 160. Refractory ascites. Refractory ascites are ascites that persist even with sodium restriction and maximal diuretic use. Addition of midodrine, an alpha-1 adrenergic antagonist, or clonidine to the diuretic therapy can help. And then complications include spontaneous bacterial peritonitis and hepatic hydrothorax. So spontaneous bacterial peritonitis, so from the word itself, there was no instrumentation done. It's caused by bacteria because of bacterial translocation. And then this happens in patients with cirrhosis. Hepatic hydrothorax is when water from the belly seeps through the diaphragm into your lungs to create pleural effusion. Okay. Usa pa. Wait. Jaundice. So our last topic is ma-open. Tuloy ba exam ninyo tomorrow even though mabaha?
Mag-wait pa, Doc, sa announcement, Doc.
Kung madadayon.
Opo.
Grabe ang baha. Pero dili man baha sa RTR. In fairness. Wait lang ha, I'm trying to open this. The last lecture on jaundice. Naghahang kasi.